It is absolutely time to start rethinking women's health, and that includes looking at solutions like natural or synthetic bioidentical hormone therapy. And to talk to this about and to talk about this today, I've invited a very special guest. I'm Dr. Patricia Mills, holistic medical doctor with a root cause approach to your health and hormones, and welcome to the Wild Wisdom Show. Today, we're going to be talking about the future of women's hormone health, natural solutions and therapies. And I am so pleased to be joined by Dr. Sarah Daccarett. She's a board certified physician working in Idaho, a hormone specialist, and founder of Inner Balance, Transforming Women's Health with natural hormone therapy solutions for endometriosis, polycystic ovarian syndrome, perimenopause, and other really difficult to manage hormone conditions that many women experience these days so that women can thrive and not just cope. Welcome, Sarah.
Thank you for having me.
Oh, it's an absolute pleasure. So I'm really loving this whole space of, women, female doctors supporting women who are looking for solutions that are natural and yet updated and very, very effective. So I would love to hear what you are doing in this incredible space.
Thank you. Yeah, we are pioneering a new formulation or a way to really address the outdated approaches that are being done. If you look at the standard of care for women's hormone replacement therapy, the bioidentical hormone therapy space, it's pretty outdated. I mean, I will go ahead and make the comment that if this is the standard of care, it's a poor standard of care, that we've made a lot of progress for men over the last decade, and women are a decade behind. We need to evaluate how we're trying to get hormones into the body. Or we should be using patches and pills and these really ineffective formulations, given how hard it is to get hormones, at a level that is protective. And so Inner Balance is a way to do this. One, we're online internationally, so giving women access who may not have it, who may not have access to a provider, but also a different formulation. So really looking at this and trying to close the gap between men and women.
Amazing. So I've, presented on this topic before, and a very common question that women, have about hormone therapy is, well, what is the difference between bioidentical and non-bioidentical? Why would you, for example, be focusing on the bioidentical space for hormone therapy?
I agree with bioidentical hormones because you get the best results. So even if they're all safe, let's say that, I think the literature shows that probably synthetics are safe too, but it's about results. When you use the identical molecular structure, you're using something that your body recognizes as its identical estradiol, testosterone, and progesterone, and it binds to the receptor, it's going to have that signal to the cell that is the most natural, and that's where you're going to get the best results. Anything can bind to that hormone receptor. We even have pesticides and plastics and chemicals that bind to those hormone receptors, and you get a bad result when that happens. You can get cancer, you can get a lot of things. If you have a synthetic chemical that's really not a hormone at all, but it mimics and binds to that receptor, and this is something that like birth control would do, or a synthetic conjugated hormone that has to be cleaved before it works. But really, when we talk about progesterone, because that's the one that's been manipulated the most, that binds to the progesterone receptor, and it will have a completely different signal to the cell. It can be stronger, it can be weaker, it can do all kinds of different things and so if you want the least side effects and to feel most like yourself and to have the best results, you should use something that the cell will recognize the receptors.
Yes. Okay. So if I understand correctly, taking progesterone as a hormone as an example, there's the progesterone that is most like our own progesterone, so bioidentical, identical to our own progesterone. But there are medications, prescriptions of progesterone that exist that are not bioidentical. They can even be natural or synthetic, right? But they are not designed to be exactly like it. And they can bind to our receptors, our hormone receptors, but the results are suboptimal. And from what I understand, a lot of the poor outcomes of hormone therapy in the past have come from non-bioidentical progesterone formulations. So I think this is so key and so important. Now, for example, you can go out and purchase a bioidentical progesterone, progestin, prometrium is an example, right? So it's a commercially available formulation. Any doctor can prescribe it. It's covered by, pharmacare or health insurances if you have one. It's not compounded, so it's not made in a pharmacy. They don't just make it up with a prescription. It's made in big warehouses, and they're available to the average person. And so, what do you see? You're talking about a new formulation, something even different from that. Is that what you mean?
Yes. So it's about the way we need to be thinking about how we get it in. What happens when you get it into the body? If you take a bioidentical prometrium, which is micronized, and the reason why they have to micronize it is because progesterone is a really big molecule and it's a fluffy powder. It's like huge. So they have to do that in order to like manipulate it to get into the body. But when you swallow a hormone, any hormone, it gets metabolized by the liver. 80% of it metabolizes the liver metabolizes 80% of it into metabolites that we don't really even know what a lot of them are. Some of them are toxic. Some of them are just anesthetics that make you sleepy, which is why oral progesterone makes women just fall asleep, which is why they kind of like it. But it also makes you groggy the next day. This one, it's a huge burden on the liver, right? You're putting a lot of pressure on the liver to metabolize a hormone, which it wasn't really ever meant to metabolize hormones. What about the other parts of your body that women probably metabolize hormones in, which the uterus, the breasts, and other tissues like the brain, instead of putting the entire burden on the liver? So I would even argue that an oral formulation, we don't give men oral testosterone. And when we have an oral formulation, but it's packaged in a way that it goes into the lymphatic system and they don't get side effects, and you're not raising liver enzymes and you're not using this huge burden on the liver. We don't do that for women. We should. So women have an oral progesterone that then is metabolized in the liver. We have oral estrogens that are metabolized in the liver that raise clotting factors that increase risk for stroke. It's small. I don't want to panic anybody on the call because this is a very small risk, but it's still there. Like, why would we, if we have better ways to get it into the body, why wouldn't we utilize those? So I feel like orals should be out of the picture for hormone therapy.
Yeah, I 100% agree on the oral estrogen. I don't think the risk is worth that at all. As you say, the effect of, going into the gut and then the liver breaks it down, it increases clotting. Now, it's interesting about the progesterone because I have seen oral progesterone, micronized bioidentical progesterone like prometrium, used to treat women who are having hormone-related issues with sleep. I have a close family friend, don't want to name anyone, who, it was life-changing for her to have the oral formulation because it did help her sleep and she's not groggy the next day. But it's not every woman who responds that way. I have met women who take the oral progesterone and they are too groggy, too tired, and they don't respond well to that one. Now, as far as I know, there are transdermal progesterones like this, you put it on the skin, and there's vaginal progesterones. Do you have a concern with those currently available options?
So, I mean, even to go back to the orals can make PMD, things like PMDD worse, so it's even just like, you can get a very bad result with the oral formulation. And if you imagine if your friend felt great and she fell asleep, but she fell asleep kind of with just a Band-Aid fix, like those toxic metabolites are what making her fall asleep. If she were to get the right amount of estrogen and progesterone, she would sleep naturally without needing this like sleep aid, which is essentially what the oral progesterone is doing. So yes, that's better than nothing and it's saving her because she's getting sleep, but is she getting the best? No. So I think that when you talk about a 200 milligram oral progesterone is only 20 milligrams of progesterone. That's it. And that you can only take so much estrogen to offset that, right? Because you're trying to be balanced. And estrogen helps women sleep too. It raises dopamine, gets them in REM sleep, helps their cerebral spinal fluid clean their brain at night. Estrogen is just as important to help women sleep. So she's missing half of the picture. Like the provider's not giving her everything she needs to sleep. And we rely heavily on this oral progesterone just to literally put them to sleep instead of just doing it correctly. So I would just comment on that. But if you look at topicals, progesterone is a huge molecule, as I mentioned earlier. It does not go through the skin. So the skin is a barrier. It's meant to keep things out. And estrogen, even though it's smaller, estradiol is smaller, only 30% of that goes through the skin. We know that it's highly variable, those patches and topical estrogens, very variable, kind of can sit in the fat layer. It can go into the lymphatic system. It can be all over the place for women. Progesterone's even worse. We think that it goes into the lymphatic system. Women do get some results from topical progesterone. You will hear them say, I feel a little bit better. They do notice the difference. So you know that 20 to 30% of it is getting in. Can you imagine how good they would feel if they had a formulation that actually worked and got into their body? Like if they're saying that only 30% of this product is getting into their body and they feel amazing, or they're like really grateful for it, if we were doing it correctly, how good they would feel. So again, like we're doing okay, like this standard is like sort of working, but I think we can do a lot better with, like, we have self-driving cars, like on the road, we can literally figure out hormone replacement therapy for women. So no, the problem with the topicals is that when you put these, like there's a surface area problem. You have to put it like everywhere in order to get the amount of hormone in that you need. And then you have 50, 70% of it that doesn't absorb. Where is that going? It's going on bed sheets and towels and kids and pets. And I've had vets call me when I used to prescribe topicals. Veterinarians would call me and be like, I mean, the little vulva of the dog, like it's all swollen, and like because they touch their dogs and the hormone creams are getting all over the pets. I mean, these are getting all over the household. We used to prescribe topicals to men, right? And then we knew that these androgels, like, it was basically these anhydrous bases that we use to try to get the hormone into the body. We stopped using them in men because it got all over children, and these high testosterone doses were causing, pubic hair to grow on 4-year-olds. And so we stopped. Like I would never prescribe a testosterone cream to a man. So even if he's putting it in the testicular area, it's still getting all over the laundry. Why would we settle for giving women that when we don't even do it for men? I think this is where we need to recognize, like, if women understood what men are getting versus what they're having to put up with, like women are literally putting on 4 or 5 different products. They have to put a patch on. They're doing a testosterone cream. They're taking an oral progesterone pill. They're doing a low dose vaginal cream. And it's because everything is such a small micro dose and barely gets into the body. And it's a crappy way to get it into the body that they're barely covering their symptoms. So if you have to use 5 solutions, is it a solution? And is it the best way? Absolutely not. And the cost adds up, and you start stacking these and you start manipulating the doses, and it's exhausting, it's expensive. And I know women who have been literally chasing this for years, trying to feel better, and they're not really getting better.
So let's say a woman comes into your office today. What would be your kind of standard or foundational protocol that you would work towards getting them onto to help them feel better with what's currently available?
So the best way to get hormones into the body can be injections, right? You can inject them. But with women, I would say it's challenging again, because progesterone is such a large molecule, you'd have to inject a lot. And I don't know about you, but I'm not into like subcutaneous injections like every day or every other day. And then if you get withdrawal bleeding, and this can be very challenging because we have a period, whereas men do not. And I don't need to call it out, but it's like going to make hormone replacement therapy a lot different for a woman. So we have to consider women that we're not doing this in just menopause, that these are perimenopausal women, in their 30s and 40s, or some of them in their 20s. Like these are younger women that are still wanting to cycle. We still need them to cycle. And so the period is something that we can't ignore. So injections might be out just for that, because you could potentially, nobody wants to have a period every 3 days either. So vaginal delivery is one of the best ways to get hormone into the body, or a drug. And we've known for 60 years how effective it is. Even though it's not mainstream, we do it for fertility medicine. We do it for maintenance of pregnancy. We have other, medications that we use either rectally or vaginally. This is not a enigma. We know that it goes into the bloodstream. The biggest thing I hear from women and other doctors is literally all the research, and every other doctor says that vaginal delivery is only local. Dr. Sarah, you're not making any sense, because everything says. They have to remember that those products were designed, the current stuff on the market are low dose, micro dose, vaginal estradiol creams designed to only be local. They're such small dosing. Then they do the study, they prove that it's not systemic, because they're trying to prove that it's not systemic. They're trying to prove that that dose is not systemic. They're not proving that vaginal is not systemic. We know that it's dose dependent. You go up on the dose and it gets into the bloodstream. And our own studies show it, that we know how predictable and how stable the blood levels are when you actually look at it compared to a patch. The patch is all over the place. Topical creams are all over the place. Orals can be too. Diet can impact it. You eat a bunch of fiber and there goes your estrogen. So I think that you have a more stable delivery method, that you get more stable blood levels. and you can effectively like get them. And it also depends on where you put it in the vagina. If you put it in the lower third or the upper third, you can get, the uterus. Naturally, if you think about it, the ovaries make the hormones and they're right next to the uterus. There is a first pass uterine metabolism effect. So a first pass where instead of using the liver to metabolize the hormones, the uterus is probably metabolizing most of the hormones naturally. So not only does it matter if you're taking a bioidentical versus a synthetic, so we talked about that at the very beginning, that women need to understand that it's important to take what's most like what your body makes, but also take it in a way that your body is used to metabolizing it in order to get the best result too. We need to understand and appreciate and respect the way a woman's body might metabolize it and try to mimic that as best we can. Because obviously our ovaries aren't working anymore. And then you can prevent side effects, because side effects are a very real thing for hormone therapy for women. Like a chunk of them will get bloating and, there's some significant side effects. And if you can reduce that and just get better results. So more stable blood levels, you get more predictable, and you can get them in a more therapeutic range where she can sleep, where she's not relying on oral progesterone with metabolites to help her sleep. But if you're getting her estrogen and progesterone levels up high enough, she'll sleep just like she did when she was in her 20s. Like she's sleeping normally then, and we didn't have to give her metabolites to help her sleep, right? So hormone replacement therapy for women right now is about treatment. We treat symptoms. We wait until your hot flashes are so bad, and then we finally give you a patch to just keep them from having 100 hot flashes a day to having 5 or something. We're just kind of trying to maintain or treat the symptom itself, like vaginal dryness. So we'll treat your vaginal dryness. We'll treat your libido with a little bit of testosterone cream. We need to think about hormones differently. They're not a treatment. They are the foundation to anti-aging, foundation to good health. If you look at anti-aging as a pyramid, they are foundational to it. We can keep metabolic flexibility with them, our skin and hair. We can keep cognitive function, bone health, pelvic health, sexual health, all of these things we can keep, and we want these to be core and foundational, and that's what they are. They're not a treatment for hot flash. We should be thinking about them in our 30s and making sure that they're optimal always. We shouldn't make women wait 20, so there's a lot. I'm kind of bringing a lot in here, but and it goes with the formulation, how can we mimic a young woman's body? How can we do that for her? And vaginal delivery makes the most sense because you are putting it near the uterus where the uterus can make metabolites. And those metabolites are pretty unique and special, and you don't get those metabolites with oral or topicals.
And I guess liver health is less important too, right? Because one of the things I see is women starting hormone therapy and they're taking oral, hormone therapy. And as you say, it has to go through the liver, but the liver has, lots of toxins going through it, accumulated over the years, the alcohol effect, just aging in general, that sort of thing, an inflammatory diet. And now you're adding another medication it needs to work on, and it can just be the tipping point. And some people can get pretty bad side effects, as you were saying. And then looking at what's current. So that's I'm hearing what you're saying. And in terms of what's currently available, because I want to ask about your specific formulation. And I also want to acknowledge that there may, when it's when you want to get somewhere, there's the steps up the ladder you have to go through. It's we need to go through this step and that step. Most of the people here, they may not have access to your formulation yet. Or is your formulation already available and people can go online throughout the world and purchase it? At what stage is that? And I'm assuming from what you're saying, your formulation is a vaginal formulation of hormones at higher doses, or is it that it's designed differently for better absorption? Because my concern with hormone therapy, and correct me if I'm wrong, because I need to learn, I'm always open to learning more and it's important to do so, is that the doses in our body of hormones are actually kind of small, right? If you look at the measurements, it's not like there's a ton of hormones floating around. It's the balance between the hormones and kind of relative to how much there should be, having too little or too much, but that amount is actually not very high. So I'm just thinking of things that people will say to kind of bring concerns about increasing the dose, even if it's delivered vaginally. So can you speak to that and kind of, settle the fears that might come up hearing about higher doses vaginally, And so I guess I've asked you 2 questions. One is, What is your formulation? Like, what's different about it? Is it currently available, and when will it be available worldwide? And is there a concern with higher vaginal doses?
So we'll talk about the formula a little bit more too, but it's only available in the US in 50 states. It's compounded. We use compounding pharmacies here. And this concern, like we can debunk the concern for the dosing thing. So let's unpack that a little bit, because I do hear you. And it's not that it's not about the amount, it's also about bioavailability, right? Like what's available for the body to use. And it's not about overwhelming your system with like a whole bunch of hormone. And we have to think though that what we currently think is a lot is actually not that much. That's the problem. So we're telling women that, for example, estrogen, let's just take this one because this is probably like the one that everybody's like freaks out about, but estradiol, when we get pregnant, our third trimester pregnancy, estradiol can get up to 40,000 picograms per milliliter. 40,000, okay? So for the upper limit of normal, like based on, probably a peak ovulation, like a 25-year-old, we have newer studies on LCMS. And the problem with a lot of the older studies done on reference intervals were done on radioimmunoassay, which we would reject from publication today because it's such a poor way. We don't even use it in the laboratory anymore. Poor way to take these measurements. So LCMS is mass spec, which is a more sophisticated instrument. So let's look at those studies only. And we look at 20 women in their 20s and their peak levels at ovulation, because we can measure it every day with like mass spec and see like the cycle. And it peaks at ovulation, and estrogen can get up to 1,000 picograms per milliliter in some of these women. But let's call it 500 because that's actually what most of the reference intervals kind of publish, and a lot of the labs have established it to be 500 picograms per milliliter. So let's look at a patch. An estradiol patch can get you to about 60 picograms per milliliter. So is that high? No, that's not even like getting you. We think that hot flashes occur when estrogen gets below 100 picograms per milliliter. So the thought is that we just need to give women just enough so they don't have a hot flash. Because again, we're just treating symptoms. We don't care if she feels young again. We don't want her to like have any anti-aging effects. This is like the current practice. So most women still have a ton of symptoms. They still have vaginal dryness, low libido, brain fog, fatigue at 60 picograms per milliliter. Some of them still have hot flashes. Okay, so the patch isn't even capable of getting a lot of women above 100. There's plenty of studies that show that it needs to be above 100 to protect brain, heart, and bone, right? To prevent osteoporosis. So we need to get it above 100 picograms per milliliter. And the patch is clearly not doing that. Okay, so our product, like if you do a vaginal formulation, one, it's more controlled delivery. You can have more predictable lab values. And it's steady state. Our product can get you to 100 to 300 picograms per milliliter. So is that high? No, it's not. It's like within a reasonable range where women can have their symptoms controlled. Nobody's talking about pregnancy levels. Nobody's proposing, like we're not proposing that we overwhelm your system and get you up to 40,000 picograms per milliliter. And even at ovulation in your 20s, you got up to 1,000, say, some women even 1,500. That's not high. That's like what we were when we were younger. We did the same thing to men 12 years ago. We kept their testosterone levels very low. We said it needed to be between 300 and 800 picograms per milliliter for their testosterone. And now it's very common practice to let men be at 1,000 or 1,500 picograms per milliliter. Now we recognize that they get longevity, they feel better, they have the physique that they're looking for, they get results from working out, they have libido, right? So we recognize these things that are not just symptoms, but that people actually deserve to look good and feel good as they're aging. We do that for men. Women deserve the same. They get to look good and feel good as they're aging too. They just don't have to like treat a hot flash. We are looking at anti-aging here and using hormones differently, and getting them up to 100 or 300 or even 500 picograms per milliliter is normal. It's within the normal range. We can't do that with a patch, and we can't do it with topicals. Okay, so that's the problem, is the current formulations are not even able to get women up to a normal. The progesterone's even worse. So like if you unpack progesterone, it's even like awful because one, there's no studies in the world that talk about optimal reference ranges for progesterone. It is literally our most abundant hormone. It's our most important abundant hormone. And we don't even know what optimal is. Like I've heard physicians say, well, it needs to be 10. And I'm like, well, what about 6? Or what about 20? Like, who knows? Like, right? There's literally nothing. There's 5 papers in the world on it. And then none of them were published in the US. They're in Canada and in the UK. So laboratories have not established this. This is like embarrassing for the medical community. And all of the studies have been on the synthetic progestin, which you mentioned at the beginning of the call, because this is a pharmaceutical product. It's not a natural product. And of course, we're going to study that one because the big pharmas pay for it, whatever they pay for it. Progesterone, though, there's a lot of confusion about how elevated or high or what protects the uterus. Okay, so if progesterone needs to be above a certain level to protect the uterus, we don't actually know probably what that is. Oral progesterone will put you at 10, okay? If you do vaginal progesterone, it will put you closer to like between 3 and 6. It's actually lower. So vaginal delivery will give you lower levels, but it's more bioavailable. The difference is that your uterus can actually use that and make metabolites and put it all around the body, whereas the oral progesterone, it's floating around, but it's not bioavailable. So you actually end up with higher levels with an oral. And then we know this for estrogen as well. So there's papers that show that even you end up with a little bit lower sometimes levels with the vaginal delivery. It's more bioavailable to the body. And when we report units, everybody else in the world, Canada and the UK, has established standard reference units. Like they're like, let's put everything in the same unit. Who would have thought that would genius, right? So they put everything in like this standardized unit, and then you can compare them. Right now, in the US, testosterone, estradiol, and progesterone are all in different units, which really confuses everybody. Because when you look at progesterone and you get this number 6 back, you're like, well, it's not very much. That's not very high. 6, that's not a big number. Nanograms per deciliter, which is 6,000 picograms per milliliter. So now you're talking about estrogen should be at 300 picograms per milliliter, and your progesterone is at 6,000, and it should be. So progesterone should be 10 to 30 times higher than your estrogen, right? And so like we're not even recognizing the ratios and that women really need to have progesterone front and center. And what formulation can do that? Like, I mean, if you look at the labs, oral progesterone is doing that because it'll get you really high. But is that bioavailable? No. So like, we like, does anybody even understand what's going on? Like, it's really a mess.
Yes. And just because I don't want to forget this question, if a woman has had a hysterectomy and they use vaginal progesterone or estrogen, does it still get metabolized to a bioavailable form, even without
Yes. So it's still bioavailable. The only thing that's missing, so the thing that the metabolites that the uterus makes are for the uterus generally. So like DHP, dihydroprogesterone, is the metabolite that regulates bleeding and inflammation in the uterus. So this, if you don't have a uterus, then you don't really need it. I guess you could argue that it does go to the central nervous system and help with mood and depression, and maybe some other things, but it's like, it's still fine. Women need to understand that it's going into the bloodstream. And that's what's making it bioavailable. And it's missing the liver. So it can get to other tissues before the liver. It can get to your brain. It can bind to those receptors. It can get to the breast, and it can be metabolized in different tissues. That's the point. When you take something and you swallow it, you're not giving it a choice. You're literally putting it into the liver first. Whereas at least if you put it vaginally, some of it may go into the liver eventually, but you're giving it like to the whole body so that it can go elsewhere. And progesterone counterbalances estrogen in every process of the body. So if you've been told that, I don't have a uterus, so I don't need progesterone is your most abundant main hormone. And it's literally like, I mean, even to maintain your blood pressure, you need both the estrogen and the progesterone. And we pigeonhole or silo the hormones into, we need progesterone for sleep. We need testosterone for libido. We need, estrogen for skin, or whatever we're doing. Like, we're trying to say hormones don't work like that in the body. Every process probably requires all 3 hormones, or at least the estrogen and progesterone. And then there's maybe selective ones for testosterone. We don't know, like, we need to study this. And so women, when they say that they need progesterone to sleep, you actually need the estrogen too. You need to be thinking about it holistically, that the hormones work together. And to get the best results, you need to keep all of them, not just one and do. So it's very common in the US for providers to just give women testosterone. They're completely missing like the other parts of the picture from that. Or they'll just give them estrogen, or they'll lower the estrogen and just give them progesterone. It's a little bit all over the place. Instead of thinking about it in women, you really do need all of the libido. You need all 3 hormones to have libido. Like when you look at the limbic system in the brain, it's covered with estrogen receptors. There's not testosterone receptors in your limbic system. So, but there's testosterone receptors in your clitoris probably. You know what I mean? So they're distributed everywhere. Then you need progesterone to help you relax and maybe put you in the mood. And so everything does need to come together for the libido, for example. So we do give one hormone credit for things, and we need to start thinking about them differently too.
A holistic approach even in how the hormones are used. So a woman comes to you, you're going to start them on a protocol. It's going to be vaginal for all hormones that you're prescribing. Is that what I'm hearing? And you have access now to your formulation. What's the name of it, by the way? Is it just like a
Oestra is our name of it.
Oestra, Oestra? Okay, cool. And how that's different from current vaginal formulations, because there are current vaginal formulations like I think it's chromium or something for vaginal progesterone and all these other vaginal estrogen and testosterone and DHEA options. So what is your kind of take on, how would you kind of, as you say, rethink the future of women's hormone therapy? What would be your ideal kind of protocol for them?
So I think when you compare it to other products, like Crenone is the FDA-approved version of vaginal progesterone. It doesn't have estrogen with it. It's okay. This, a lot of it can be the base, can be, Big Pharma uses different chemicals in their bases. We try to use something that you discharge so you don't absorb the base. I've seen them packed in suppositories, which are like huge, and they're cocoa butter and they melt and they're messy. I've heard of providers like giving women prometrium and having them put that vaginally. And then you have like leaking peanut oil out of your vagina. And so this is like also, we can do better, guys. Like, so I think that it's about the formulation. Crenone, you have to put a lot of cream on. It's not an experience that I want to experience as a woman. When I went through it like 10 years ago, like in my 30s, I wouldn't want to do that. It's kind of shameful. And then you're already experiencing all this stuff. And now you have to put on this whole bunch of cream vaginally, and it's not fun. So we need to have the form function better for women. They need to have a better experience too. And Crenone is really expensive. It's over $200, $400 in some a month for that. Okay, so use something more affordable as well, and it's not covered by insurance. So I think that that's also something to take into account. When you put testosterone vaginally, this is also a common, popular thing. One, testosterone converts to estrogen a lot. And let's talk about testosterone for a second because we kind of missed it. Testosterone, when you try to get that into the body different ways, you get different results too. So if you put it on the skin, it converts to DHT and it can make your hair fall out. Okay, so this is like very potent way to make your hair shed. If you inject testosterone, it can over-convert to estrogen and really make you feel very irritable or wonky if you don't have enough progesterone to offset that feeling, or it can mess with your immune system a bit. Like there's some results, some women, if you do it right and you can get it right, pellets for testosterone, one, they're expensive, but they can also get you really high. So they get women above 700. Everybody's worried about estrogen getting high when they're pushing women up past what men are for testosterone in some clinics. Like it's a little bit like, this is not our main hormone. We shouldn't be making this one so high. This is the one with probably all the side effects. Women end up gaining a lot of weight. Mm-hmm. Men gain muscle. They love it. They gain weight. Testosterone is like kind of this hormone that it's anabolic in a way. Women just get bloated and gain weight, like if they get too much. Like if you get the right amount, it's perfect. So the idea is you want the right amount of the testosterone. And if you put it vaginally, you have the risk of disrupting the vaginal microbiome. And this is really important that so we have all these other things to consider for women that we don't have for men. And the microbiome vaginally is one of them. It's really important because it's like a quality of life for women if they're having infections every month, UTIs, BV, yeast infections, HPV. And women will feel pretty good on testosterone when they're on testosterone only, but I hear all of them say, I still have like a little funkiness down there. It's not quite like what it should be. And it's because you haven't taken that microbiome into account. So testosterone, I would argue, shouldn't be vaginally, and neither should DHEA. And DHEA just converts heavily to the testosterone, and you're just trying to do that from like a precursor standpoint. What the vagina needs is estrogen, because Lactobacillus acidophilus, that bacteria, when we talk about diversity, it's great for the gut, but we don't want diversity in the vagina. We want only one or two or three strains, like max. These strains keep our vagina very acidic and very healthy. You want like a good, even just if you have a funky odor, there's a sign that there's something going on there from the microbiome standpoint. The acidic environment makes it really hard for yeast, E. coli, HPV, like all these pathogens to survive. And let's be honest, like the vagina is like exposed to these potential pathogens that we need to be able to fight. It's like its own immune system, its own immune barrier in the vagina. Estrogen, Lactobacillus acidophilus, which is the primary bacteria there, need estrogen to make its food. So if you don't have estrogen present, you're not going to have this nice acidic environment to protect yourself against these infections. So it's not testosterone that's like giving you that vaginal lubrication. It is when it converts to estrogen, and the estrogen's helping, and it will help with that microbiome. So again, like this, it is important. And vaginal estrogen, estradiol, and progesterone are what we use in our formulation. And then we let your body regulate the amount of testosterone that's made. And we don't appreciate that testosterone just converts from progesterone. So progesterone there's a pathway, there's enzymatic conversions, and your body will make it. And then you're allowing her, like yourself, to kind of regulate that. Maybe you genetically make more or less than me. Like I or maybe somebody who's more active and lifts a lot of weight. I mean, who knows, right? But it's her genetics and her pathways that dictate that, instead of us or me as a doctor pushing this amount on you and trying to like prevent a side effect, because it's actually really hard, because I don't know what your optimal testosterone is. Maybe you need to be higher, or maybe you like it lower. I mean, this could be, does that make sense? Some people want to be at 70 picograms per, or 70, and some people want to be at 20. And so Oestra, like our vaginal delivery, we do get systemic rises in testosterone, and they are normal. 10 to 30 is normal. Okay. It's not going to get you to 70. So if you want this like raging testosterone levels, you're going to have to do it, supplement it extra. But the good news is that it's easy. Testosterone is like the easiest one. You can do a little bit of DHEA. You can even try like some herbs like ashwagandha or maca, or like these ones that kind of boost testosterone kind of subtly. Or you can try a testosterone cream, and then, make sure you don't get the side effects from it. So there's options for the testosterone. I would say it's the easiest one. It's the one that we've kind of figured out the most. And that's why providers tend to kind of lean towards that one. But for women, it's super important that you get progesterone and estrogen right. We can't even figure those out. Once you got to get those balanced first. And then if the testosterone doesn't fall into the place, like if your body is not making as much as you want, then address it. But when you have your uterus that, hormone replacement, like women go years and they need, their uterus is like, there's a lot of bleeding and there can be breast tenderness, and they need to resolve these first. And testosterone, throwing it into the mix, can sometimes make that water muddy and make it hard to do that. So if you are to stack something, it is testosterone. So getting the progesterone and estrogen correct and getting them in the right ratio, and then kind of manipulating or adding testosterone is better. You would get, like, then what's doing what. Did the testosterone help you? Did it make you gain weight? Did it give you a libido? Did it make your hair fall out? Like, do you hate it? Do you love it? At least you know what that hormone's doing to you, because that's the one that tends to be like, some women love it, some don't. So does that make sense with the testosterone? So you kind of, the formulation is just the two hormones.
Right. Just estrogen and progesterone, and getting enough progesterone allows the body to have enough building blocks of progesterone to then convert into testosterone. And then you're kind of letting the body decide. And once you've done that for a little while, if you yourself would like a little bit more testosterone effect, you would layer that on in many different ways. But many don't have to. So that's amazing. So you would start women off on a vaginal estrogen progesterone, formulation. Oestra sounds like what you're saying is it's, more bioavailable, larger doses, so it's easier to get to those systemic levels compared to current formulations. Now, it's a bit more intuitive when it comes to perimenopause, right? You have declining amounts, so you're allowing yourself to kind of get external inputs, right? What about endometriosis and PCOS? I know you mentioned that as, one of your missions to help women with. Where does that line up? Because, for example, the current standard is many doctors will prescribe an IUD, to manage those symptoms. And IUD is just, why don't you explain why you maybe wouldn't agree with an IUD and you prefer something like what you're talking about, which is a combination of estrogen and progesterone?
Yeah, I think with this very common like birth control, it's either an IUD I've heard or oral birth control for something like endometriosis, even PCOS, both of these, they just want to shut the whole system down. Like essentially birth control is different. It's not hormones. It binds to the hormone receptor. Kind of we talked about at the very beginning, like circling back. It binds to the hormone receptor, but it lowers the production of your own hormone to zero, which is what makes you infertile. That's why it works as birth control, is because you've lost your own natural progesterone and estradiol, which we need to get pregnant. Okay. So like this is how birth control works. And nobody's informed of this. There's no informed consent that this is what we're doing to you. So that's how birth control works. We're stopping this, and it just gets rid of that period, which is the most painful part of it. But most endo patients and PCOS patients I've ever met, doesn't make them better. It kind of takes away their pain because the period tends to bring them pain for the endo patients. But they still have pain during sex and bowel movements and exercise, and they still have bloating, and they still have a lot of anxiety. They have trouble sleeping. The birth control can make their mood worse because you're taking away these protective hormones. You've just stopped the period. And then they tell them that if it doesn't work, then I've seen hysterectomies in like 30-year-olds for endo, to get rid of it. So this is a problem. And it's not just if you haven't been officially diagnosed, painful, heavy periods is like rarely common, right? So even if you're not, it could be, even if, let's just talk about one. Endometriosis is an inflammatory condition too. So this is what's causing this chronic pain, is this tissue that falls outside of the uterus. The immune system recognizes it right away as being, that uterine tissue is supposed to be in the uterus and not in my body, like in my lungs or like wherever. It attaches everywhere. And the immune system sends like a response. And this is what's causing all of the problems and pain, is really the own immune system. And so you have to address all of it. You can't just stop the period and then expect it all to go away. And doctors don't really think about birth control, and they think it's hormones. I do. I don't think doctors are trained on it. If the difference is, if you use a bioidentical hormone, most of these endo patients are low. They're not like, there's like this really big overlap between even perimenopause and endometriosis. And like, how do you know their ovaries aren't failing? Or did they get exposed to birth control and chemicals in the environment, which are literally inundating, like kind of bombarding women on a daily basis? I get pesticides, plastics, phthalates, fragrances, like you name it, and they're binding to the estrogen receptor. Okay, so they're lowering. So potentially, as endo patients, are the endometriosis patients the ones that we put on birth control at age 15 to control their period, and we never addressed it at age 15, and now they're 25 and they have a full-blown endometriosis? Like, is this we've done this? Like we have to like really talk about it. And so giving her more of the problem, which could have been birth control in the first place, you're just giving her more of it. Bioidentical hormone replacement therapy is different. It replenishes or enriches back what you're missing, and it allows those tissues to heal. And when you give it vaginally, you make a substance called DHP, which I mentioned. The uterus will make DHP, and DHP overcomes progesterone resistance, binds to the receptors. It lowers inflammation. It stops the heavy bleeding. I mean, this is like how nature is controlling why some women have endometriosis and some don't, right? So they're completely different. When you take an oral birth control or use an IUD, this is progestin. First of all, it's not progesterone. It doesn't make DHP. There's no DHP like in the picture. So you're just stopping the period. PCOS, same thing. Like the problem with PCOS is that you have elevated LH. This is the root problem. I hear all the time that it's insulin resistance, and that's the reason. Yeah, but that's a symptom. Insulin resistance is your symptom of part of the whole thing that you need to look at. But we're not, and you tell a woman to just lose weight who has PCOS, we're going back to this just treating one symptom. We're not looking at why LH is elevated in her brain. And when LH gets elevated as high as it does, it stimulates testosterone production. And the ovaries are really sensitive to testosterone, and they're really sensitive to insulin. And when they have too much insulin, they make cysts and they make these follicles like all over the place. And even if I'm hearing, I already hear it like from viewers who are like, well, what if you don't have elevated LH and you don't have cis? And like, I get that there's like different variations of PCOS. I'm just talking about the classic one, or what really can so that we can, so I can make a point about how if you look at the LH and you lower this in the brain, then you'll get the ovary to stop making so much testosterone, because it's the testosterone that's giving her insulin resistance. I mean, we're like, you have to lower that. You can tell her all day long to eat certain diet and certain restriction to lower this insulin resistance, and she can still have this raging testosterone that's causing her hair to grow on her face and her hair to fall out. And so again, you have to lower, and the only way to lower that, the reason why the LH is elevated to begin with is because there's no progesterone present, right? So something happened to her. Could it have been birth control or the chemicals in the environment or whatever? This 28-year-old now has PCOS. And why did somebody get PCOS and somebody got endometriosis? Genetics or environment or diet, or who knows, like why one pathway dominated and not the other. But the root cause is all because she had low progesterone in both of those cases, right? So you have to address these, and you can't do it with birth control. So doctors are traditionally trained to think of birth control as hormones, and they're translating that to patients, and patients need to be the one that's actually standing, because doctors, they don't have time. Like, you have to either go to a specialist or, like, OBGYNs, they're surgeons, they deliver babies. I respect them. I can't deliver babies and do surgery, nor do I want to. So like, let them, but they don't need to know your hormones too. You got to go to functional medicine doctors, hormone replacement therapy specialists, longevity doctors, people who understand that, because they at least know that core difference that we started out the podcast with. So if you're trying to do it with birth control, you're not going to be able to lower LH. It actually artificially will stop and suppress LH, but you're not doing it. You're not giving then the environment with the progesterone and estrogen to reverse that dominance that you have with the testosterone. It's totally the only hormone around. It's wreaking havoc. So, and I hope I answered your question, but you're even though they don't have studies to really prove that you're treating a root cause or that you can cure PCOS or cure endometriosis. Nobody's making that claim, but you're at least trying to address this underlying deficiency and a root cause, which is if you address the root cause, you're going to be more successful.
Mm-hmm. Yeah, no, absolutely. And it may not be, as you say, like the root cause, but if the root cause, which we're still working on, really, like you say, is it toxins in the environment? Is it extreme stress situations? Because stress drains progesterone, etc. At least while we're still figuring that out and cleaning up the body and managing stress, giving that progesterone will provide a more root cause solution closer to that root cause, further upstream, so that everything downstream from there is fixed, as opposed to getting to like that very end. And as you say, it's like, well, let's just shut this body part down. It kind of makes it so that we don't have very many options in the future, right? Because we're not actually providing a body like the environment that it needs, as you say. So I really love that. And when you're prescribing Oestra, what is the difference is the formulation coming in a specific dose? And so every woman is getting the same dose, or is there like a dose scale that you use? How does Oestra?
We can use the scale. Like, I really wish that women could all get the same dose. It would be so much easier. Wouldn't that be amazing? Because like, in men all get the same dose of testosterone. We literally give them the exact same thing. Like, everybody gets the same thing. And you can kind of titrate down if you want, but really there's the standard that they get the standard. So women are harder. It depends on the health of their uterus and their age, but you can, scale it, and you can titrate up. So like anything else, you want to start at a starting dose. So you want to just get started, make sure that you don't have side effects. Okay, so with any hormone replacement therapy, like even if it's not Oestra but something else, generally your provider should be titrating, starting at like something, make sure that you're tolerating it, that you're feeling better, that you're noticing a difference, that you like the application, and then go up from there. Mm-hmm. So I think the question is more like, can you predict a starting dose? Because like, I think everybody can end up at a different dose, right? Depending upon like how they end up titrating. Diets can impact this. So women think that manipulating and chasing the dose is the answer. I think they need to recognize how much diet influences hormone and levels of hormones. They'll do long fasts, and then their hormones will like tank. And even if you're taking it, like, externally, And you're just like, so maybe we should be fasting because you have hot flashes now. And they're calling and saying that the hormone replacement therapy is not working anymore because I have hot flashes, and they just fasted for like 24 hours, right? So fasting and eating really high fiber diets will lower your hormone levels. So if that's what you're going for, then go ahead and do that. But most of us are trying to get them up to levels where we don't have symptoms. So again, everybody's worried about it being too high, but it's not the case. It's generally you actually have to work at getting these levels up as we age. Okay. So this is really hard to do. So you're trying to keep them like elevated enough and consistent because the body eliminates them really quickly. Okay, within like hours. Like that's why we have to put on hormones every 24 hours because they're like gone. So if women think that they're like around for 3 months. I'm like, if they were around 3 months, we'd only have to apply it once every 3 months. Okay, so that's why we have to do these daily applications. So our body's constantly like metabolizing them, methylating them, and getting them out of the body. So keep in mind that it's the starting dose that you want to just get started on. So we put everybody on a starting dose, and it's different based on like where you're at in life, or if you have endo or PCOS or menopause or perimenopause or something. But that starting dose is where you can get grounded from, and you can kind of titrate there. Since it's a cream, you can do a little bit more, a little bit less, and women should have control over this a little bit. You can't do a little bit more than we send. Like you just got to do that or a little bit less, right? But the idea is that I think the question that you're really getting to, which we have a lot of questions about it, is like, why am I the same starting dose as another person if my labs were different than somebody else, right? Because it's kind of like intuitively, people think that if you have a certain level, like if you're perimenopausal 40-year-old who's making a little bit of estrogen still, and she's making no testosterone and progesterone, should she just need testosterone and progesterone and not any estrogen, right? I think that's really like, she's kind of theoretically making some. This is like a very false misconception about hormones work in the body, because when you start taking hormones, it suppresses your brain. It suppresses this substance called FSH, which is what your brain is stimulating the ovaries to make more. And so you're going to suppress your own production. So even if you're 40 and you're making a little bit of estrogen, congratulations, like not a lot of us are, but it's going to suppress it. So your friend and you, even if you started out at different levels, you're going to be suppressed and kind of end up at the same level, because this is like in your body. You're going to end up at the same level because your body will regulate it. So your body is going to regulate how much is there. Okay, so if I'm not giving you enough, which is often the case with the starting dose, your body will still make a little bit if it needs it, right? So it's still going to keep that FSH going, and it's still going to stimulate, and it's going to still try to make it if it can, although your ovaries are failing, right? So if your friend doesn't need as much, then her FSH will be suppressed and she won't make as much. So you have to remember there's feedback loops from the brain to the ovaries. Your body is very intelligent. Okay, so we forget how intelligent the body is. And so it's not a matter of like, I don't actually need to chase the labs and constantly try to your body does a lot of this regulation and eliminating the metabolism of the hormones. And again, as I mentioned, like what if you have this really high fiber diet and your friend has a carnivorous diet, she's eating mostly protein, you guys are going to end up with different levels anyway and different results. So diet impacts it, genetics impact it. If you have certain genes or single nucleotide polymorphisms that are epigenetics that are impacting your metabolism, this is also, and these are not in blood levels. So I think the core of your question, I could be wrong, but it's really like how do you know this and how do you do it without the labs? And women need to understand the limitations of the labs, and they do need to trust their body. And we're not doing anything crazy. We're just giving you a small starting dose to try, and then we can titrate up. So if your symptoms hopefully most of your symptoms clear up, like hot flashes, vaginal dryness, and sleep, and some of these big ones, like we really want the big ones to go away the first 2 months. But if your libido and your energy level and I'm still not losing weight, and I really want to make sure my skin and hair get really nice, and there's some things, some wants that you really want, maybe more anti-aging effects kind of later, but we want to make sure that the core problems are going away, which is usually sleep and mood and dryness and hot flashes and things like that. So those go away with the starting dose. And then we can work on going up to try to titrate to get you to feel your best. So the first 3 months are about healing and making sure that your core problems are going away. Anxiety hopefully goes away. And then we optimize later with titrating. So women can be assured that I can't predict. I have no crystal ball. I don't know what your dose is. Like nobody knows what your dose is. No doctor does. And even with our current formulations, we don't know. It's literally like the same thing, 200 milligrams of oral progesterone, 0.5 milligram patch. Like it's all the same. So, and it shouldn't be that individualized because your body is what's regulating it. Again, that message is that we need to work with your body. And the best way is to really actually turn inward and recognize, do I feel better? Like, do I have less bad days, now? Like, is it kind of slowly getting better? Because hormones are natural, they're subtle, they're meant to be like foundational. Women, you shouldn't turn into like a different person in like 8 months. It should, or you know what I mean? It's kind of like you want to see yourself consistently getting better. I feel younger than I did 6 months ago since the hormone replacement therapy, and that's what it's offering for me. And that is a better marker, and those are better markers of success than an absolute lab level. We'll do the labs, and you can get labs, and it's fine. We can look at them, and you can use them as guidelines. They're definitely helpful. But your symptoms and how you're feeling should always trump like some lab test.
Oh, I love that. I completely agree. That was very illuminating. Thank you so much. And I have one more question and then we'll wrap up. So I want to respect your time. So the last question, is that when you're dosing it, like, there's this debate, do you do it continuously, every single day, or do you take a break for a week, 3 weeks on, 1 week off? What is your perspective on that?
I think that women do need to cycle still most of the time. If you're postmenopausal, but you're still going to have a potential spotting and bleeding a couple times a year on a good systemic HRT, if it's systemic, it has the potential to make you spot. But for younger women, it's really good. Like in nature, when the egg doesn't get fertilized, the hormones drop to 0 and you get a withdrawal bleed. That's what happens in nature. Every month is a withdrawal bleed. So you can mimic that cycling with hormone replacement therapy by simply stopping the cream on day 27 or day 28, having a period, and then starting the cream again 5 or 6 days later after your period stops. And every month you are continuing to have that and mimic it. And we think, maybe we need to shed this lining to detox. There's a reason this is happening. So if we can keep this going, the thing about vaginal delivery of our hormones is that it really prevents estrogen dominance. So sometimes there isn't any bleeding and women are like, I screwed it up. I'm missing my period. And it's like, it's okay. It just means that lining didn't build up. There's nothing to shed. So just try again next month. It's more about taking a break, getting the break, giving the receptors a break from the hormones every month too, because then you're preventing this like desensitization of it. You're making sure that they still respond to the hormones, because we hormones in our body like ebb and flow, right? So giving a break from the receptors, you are mimicking that naturally. I would say this is the best thing to do. Practically, does every woman want to do this? No. And I've been working with women for 10 years now, and half of them will be like, no way, I don't want to do that. Can I skip it? This is usually the question. And so the question is not what's the best for me. The question is usually, can I skip it? And that's okay too. I get it. You're busy, you have a job and kids and a life. At least skip it a few times a year, right? So if you're trying to skip every other period because it's really hard, because you have some symptoms when you stop the hormone replacement therapy and you don't like that, and you're traveling or whatever, you're going to a vacation. But try to do that as often as you can. And I agree with the cycling. You shouldn't be doing it continuously. And younger women actually can't. You can try to skip periods, but eventually it's going to catch up with you. You're going to get bloated and crampy, and that bleeding is going to come.
Yeah. And for menopausal women, would it make sense to be on Monday, Friday, off Saturday, Sunday? Is that a good cycling option for them? Because they don't necessarily want to bleed, but maybe it's not ideal for them to be on continuous dosing. What's your opinion on that?
If they stop it, they're going to bleed, right? So if you're on a good systemic HRT and you stop it, you're going to have a withdrawal bleed. So menopausal women also need to consider, some of them, I think most of them will wait until they're spotting and then they'll stop it, have a full period, and then start it again and just try to do that a couple times a year. So can take it continuously until there's breakthrough bleeding. But if you try to cycle, the reason why it works for other products is because it's microdosing anyway. You're not getting up high enough to cause that bleeding anyway. So it's not really systemic in that sense. So you can't have your cake and eat it too. You can't have youth and great skin and hair and libido and energy and no brain fog and protect all these things and just ignore your uterus and think that your uterus isn't going to become sort of young again and turn over. And this is literally what a uterus does, is bleed. So I get that you're menopausal and you don't want to, but on the other hand, it's it's not that big of a deal to bleed like a very light period of a couple times a year. So if it means like feeling great, I'll have a period till I die. Like it's, I mean, like I think we need to like be a little bit realistic about it. That if you want systemic therapy, again, men don't have to deal with this, but like if you want systemic therapy as a woman, there's potential for spotting and bleeding all on the therapy, even if you're postmenopausal, right? And you can get checked to make sure that this is like not anything, malignant going on there, but it's usually normal. Like it usually just happens with HRT that's systemic. So I just like our formulations cause less bleeding, right? We in our menopausal women, but any HRT could do this. So really just kind of have your goals in mind. When I say if you're postmenopausal or menopausal, what are your goals? Are they anti-aging or are they just simply stopping a few hot flashes? Because if you just want to stop hot flashes, then stick with the traditional formulations that are less likely to make you bleed. If you're okay with the anti-aging and the bleeding a little bit, then we might be a better choice for you. So I think you just need to be informed as to what's going to happen if you're menopausal or postmenopausal, and then be okay with that. So if you're, make the choice, like that's it. So just know that the more you go up, the more likely you will bleed. And so that's what it's just about informed decision. If you absolutely do not want any bleeding, you've got to stick with these really, really low doses.
Yeah, it's like proof of effect. The bleeding is just showing that you're getting high enough doses so that when you stop, you get that, as you say, youthful effect of the uterus. So just to clarify, this is when you use vaginal hormone therapy in this way, it is not birth control. You are not shutting down your ovaries. So you do have to use other birth control methods. The barrier method is 99% to 100% effective so long as you apply it properly and it doesn't have a hole in it, which is actually more effective than oral contraceptive and IUD and much less risky. So people have this weird conception about the barrier method. Some people don't like the feel of it. So there's other options out there. But just to clarify, and so I just love that you are working in this space because I have not gone through menopause yet. I'm in my late reproductive stage, probably going to hit perimenopause in the next year or couple of years or so. And I'm preparing myself. I know a lot about things from research, and from working with women and clinical work and that kind of thing. But when it comes to making decisions for yourself, it's interesting because you do get nervous about side effects, about cancer risk, about, all these different things. So for those of you who want to go deeper, there's a couple of things. Some of them are resources with Dr. Daccarett. So I want to share her resource, which is her website. And it's www.innerbalance.com. And she's got a free offering for those who go on there and check it out. I believe you said it was $50 off for first assessment, right? So an online platform. Can people outside of the US access your resources?
So they can look at the website if they're just doing research, absolutely. Or they can go to if they just want to ask questions and be fully informed, they can definitely do that.
Amazing. Thank you. I do have a large US audience, but also global. So it's good to know. And for those of you who want to understand more about, kind of more the nitty gritty basic information about hormone replacement therapy, about what's currently available, about the risk of cancer and how that's been debunked, but that hasn't really filtered down to the doctors. But it depends on the formulation. So bioidentical versus not, and whether it's given oral or not, or if you're protecting the uterus with progesterone, all of these considerations. So I have a whole playlist on my YouTube channel, Dr. Patricia Mills MD, and you go to the hormone therapy playlist. I also have a hormone health playlist, an endometriosis and PCOS playlist, because we've talked about hormone therapy as one of the root cause solutions, recognizing that when we're doing holistic health, you are looking at diet and exercise and stress and toxins. And so, this is one of the portals into root cause healing, but you do need to keep an open eye to everything else in that space. So anything to say about that, Dr. Daccarett?
No, I agree. It's amazing. Yeah, what a good resource.
Okay, great. So if you enjoyed this episode, please put your questions and comments below, especially on YouTube. That's where I tend to check it most. And subscribe, so you can get updates on when I have new episodes, which are released weekly. Save this episode for future reference and share. Sharing is caring, and you never know when someone might benefit from this wild wisdom. And thank you for joining us today. Hope you have a wonderful rest of your day, evening, or night, depending on when you catch this. And I'll see you next time. Thank you, Dr. Sarah.
Thank you.
Bye.